This is Dr. Amina Firdaus, working as a Senior Clinical Fellow in Prince George Hospital, Wales. My presentation is on audit on the prerequisites of assisted vaginal birth. So what was the aims and objective of this audit? To scrutinize the clinical parameters in cases of instrumental vaginal delivery, both the forceps and vacuum extractor, with a view to improve the overall clinical outcome. And to improve the ultimate clinical outcome by ensuring that appropriate and standard practice is followed in the performance of these procedures. The methodology we have followed are this was a retrospective audit, and we have taken as a guideline RCG Green Top Guideline number 26 and the COMTAF Morgan University Health Board Guideline on assisted vaginal birth. Data were collected from case notes of instrumental vaginal deliveries, forceps and vacuum conducted at Prince George Hospital between July 2024 and December 2024. A total of 64 case notes is available were retrieved by the clinical audit and effectiveness department staff of the health board. The collected data were then analyzed in line with the items specified in questionnaire. The Green Top Guideline 26 on operative vaginal delivery has clearly outlined some safety criteria for assisted vaginal birth. They have divided it into full abdominal and vaginal examination, preparation of mother, and preparation of staff. We have emphasized on the full abdominal and vaginal examination, which is showing the head should be less than or equal to 1/5 palpable per abdomen, in most cases not palpable. Cervix is fully dilated and membranes ruptured. Station at level of ischial spines or below. Position of the fetal head has been determined. Caput and molding is no more than moderate or +2. Pelvis is deemed adequate. The preparation of mother, clear explanation given and informed consent taken and documented in woman's case notes. Trust established and full cooperation sought and agreed with woman. Appropriate analgesia is in place for mid-pelvic or rotational birth. This will usually be a regional block. A pudendal block may be acceptable depending on urgency, and a perineal block may be sufficient for low or outlet birth. Maternal bladder has been emptied, indwelling catheter has been removed or balloon deflated, aseptic technique. Preparation of staff includes the operator has the knowledge, experience, and skill necessary. Adequate facilities are available, like equipment, bed, lighting, and access to an operating theater. The backup plan should include for mid-pelvic birth, theater facilities should be available to allow a cesarean birth to be performed without delay. A senior obstetrician should be present if an inexperienced obstetrician is conducting the birth. Anticipation of complications that may arise, like shoulder dystocia, perineal trauma, postpartum hemorrhage. Personnel present who are trained in neonatal resuscitation. The health board guideline almost has written the same prerequisites for the assisted vaginal birth. So what clinical questions we have picked to be answered? Are we documenting abdominal palpation and station prior to attempted instrumental deliveries? Where documented, what proportion of attempted instrumental deliveries are less than or equal to 1/5 palpable? The ideal answer is 100%. Where documented, what proportion of attempted instrumental deliveries are at spines or below? The ideal answer is 100%. So as I mentioned before, the data included are the 2024, which was collected from case notes of the patients, 64 patients for review, 22 cases excluded due to the unavailable documents. 3 sets of notes had incomplete documentation. Actual number included in audit was 39. Data did not include the failed instrumentals that ended in cesarean section in the preliminary data. So this is the data, the diagram showing that how many patients we have included. About 60.94% were included in the audit. So what we got from the questions. Are we documenting abdominal palpation and station prior to attempted instrumental delivery? Yes. According to our the notes, we have found that 100% documentation was completed. Where documented, what proportion of attempted instrumental deliveries are less than or equal to 1/5 palpable? The ideal is 100%, where we got that 5% was documented as 1/5. Where documented, what proportion of attempted instrumental deliveries are at spines or below? Yes, we have documented, and it was found 100%, which is the ideal. So yes, the first question, it is showing in this diagram that the palpation, abdominal palpation and station was 100% documented. And we have found that were documented what proportion of attempted instrumental deliveries are less than or equal to 1/5 palpable. So 100% documented, and in only 2 cases we have found that 1/5 palpable. Other than that, we haven't found that the head is palpable in the abdomen. So this is the pro forma we fill up during the operative vaginal delivery, and specifically we have emphasized on this box like how much abdominal palpation, the station, about the caput, bladder catheterization, cervical dilatation, fetal position, and molding. So this diagram is showing that where documented what proportion of attempted instrumental deliveries are at spines or below. 100%, in majority, that is 62% of the patients, the fetal head was at +1 station. And in 20% cases, it was +2 station. So what issue we have identified? There is no clear documentation in the clinical notes or pro forma of a failed assisted vaginal birth, which turned to cesarean section. Only the successful assisted vaginal birth data has been taken. A clear picture of it is not giving a clear picture of the reason for the failed instrumental delivery. Documentation, particularly for abdominal palpation, was poor and needs the improvement. The way this information was recorded varied greatly. Some recorded on a formal operation note via the triage system, some wrote it in the clinical notes, and some used the instrumental delivery pro forma sheet. Due to the merging of hospitals and taking on patients of Princess of Wales Hospital, a lot of the notes were incomplete. So what are the recommendations? The documentation of this information should be standardized and completion of the given pro forma should be strictly followed. Data needs to include failed instrumental deliveries which led to cesarean section. This is more challenging to gather retrospectively. A prospective audit may be helpful after promotion of the importance of clear documentation. An audit should be done on all the deliveries to see whether the prerequisites have been followed or not, and the reason for failed instrumental delivery. Regular audits and re-audits should be done to ensure that cases of assisted vaginal birth are being managed properly and that maternal and perinatal outcomes are continuously optimized and improved. Thank you.
I'm working as a registrar in University Hospital of North East, United Kingdom. So the topic of my presentation is the timing of Category 1 and Category 2 cesarean section audit. Basically, it was a quality improvement project. Yeah, next slide. Yeah, so it's basically a retrospective audit assessing the timing of cesarean sections, which were documented as Category 1 and 2 on Badger between August 2024 and January 2025. To see whether they meet the guidelines regarding timing of delivery from decision. And audit then assessed common themes for delays and to identify any potential learning. Next slide, please. Next slide, please. Sorry. So these are the Royal College guidelines for category 1 and category 2 cesarean sections. Basically, category 1 is whenever there is an immediate threat to the life of the mother or the baby, and we need to deliver the baby within 30 minutes. And category 2 is the maternal or fetal compromise, which is not immediately life-threatening, but still we need to deliver the baby within 75 minutes of our decision. Next slide, please. So the total number of category 1 and 2 sections performed in that 6-month period was 198. Amongst them, category 1 was 71 and category 2 was 127. That is, category 1 were 36% and category 2 were 64%. Next slide. So amongst that sections which were conducted in 6 months period, the number of the patients, number of the cases which met the 30-minute deadline amongst category 1 were 77%, 55 patients, and that breached the 30-minute deadline were 23%. And the reason for the delay were anesthetic delay in 4 cases, transfer to theater in 3 cases, operative difficulties in 1 cases, and patient wishes for delay was 1 and unknown cause were 7. Next slide, please. In category 2, the cases which met the 75-minute deadline were 96, 75%, and breached the 75-minute deadline were 31, 25%. The reason again for delay were anesthetic delay, transfer to theater in 4%, operative difficulties in 3 cases, patient wishes for delay were 1, and handover as the ops team was busy was 1, delay due to other clinical priorities were 4, occupied theater were 4, and unknown causes were 9. Next slide, please. So the learning points were the cause of delays in unknown, it was 16 cases. So it's very important to document on the Badger operation notes regarding why a delay has occurred. Anesthetic delay was accounting for 9 cases, which we need to consider whether a general anesthetic would be more appropriate for CAT1 rather than multiple attempts at a spinal or epidural top-op. Transfer to theater was the cause in 7 cases. So we should utilize all available staff to minimize delays in transfer to theater. And occupied theater in 4, so additional theater with staffing, and delay due to other priorities were 4, so we need to continue prioritizing patients. Operative difficulties were in 4 cases as well, assess the case and call for early help. And patient wishes were 2 because ensure appropriate counseling occurs so patients are aware of risks involving with delay emergency deliveries, and handover was assess situation and act accordingly. Next, please. So action points were to disseminate learning to all staff involved with the provision of emergency maternity care to reduce delays, ensure that the obstetric team consider reason for any delays and know where to document this on the operation notes, and repeat audit to assess whether this has improved the timings of emergency cesarean section or not. And can we share the other presentation as well, the other audit, the cycle 2 of our audit? So this was a cycle 2, which we conducted after the 6 months after the cycle 1. It was again a timing of a CAT1 and 2 cesarean sections. Cycle 2, that it was a re-audit. Next slide, please. Again, it was a retrospective audit and was conducted to assess the timing of CAT1 and CAT2 in the next 6 months, that is February 2025 till July 2025. Audit evaluated whether the decision to delivery met the established guidelines for urgency classification, and audit aimed to identify common themes of delay and highlight areas for potential learning and quality improvement. Next, please. And again, our recommendations were the same. Royal College NICE guidelines, category 1, baby should be delivered within 30 minutes of decision, and category 2, the baby need to be delivered within 75 minutes. Next, please. So the audit results were with improvement. Total number of CAT1 and 2 sections were 265. Number of CAT1 were 39, CAT2 were 55, and number of undocumented cases were 5.3%. Next, please. So again, like which met the 30-minute deadlines were 72%, and which breached was only 27%. Again, the reason were anesthetic delay, transfer to theater, busy theaters, operative difficulties, and unknown causes, which were not documented. Next, please. And amongst category 2, 81%, which was a quite improvement. They met the 75-minute deadline, and 18% didn't met. Again, the reason were busy theaters, transfer to theater, other emergencies, and unknown causes were 7 in the 7 cases. Next, please. So again, the delay analysis and recommendations for practice were, it was very important because we identified audit 1 and 2 that there were 23 cases in which there was unknown cause for delay. So it was very important of documenting cause of delay on badger notes, detailing why a delay has occurred, improve documentation in real time, adding a reason for delay is very important. In 9 cases, busy theaters. So busy theaters can delay emergency C-section. So establish the theater prioritization for obstetric emergencies, effective use of standby theaters for Cat 1 and 2 sections, and assign a clear coordinator to secure theater promptly. Next, please. Other were in 9 cases, non-clinical delays can occur, such as delayed blood results, waiting for partners to arrive. So it's very important to provide clear antenatal intrapartum counseling on the need for rapid action in case of emergencies. During emergencies, priorities, clinical safety over non-essential delays, ensure all essential blood samples are taken and processed early. Rapid communication with labs point of care should be utilized. And anesthetic delay was 5. Delays can occur, such as conversion from spinal to general, and other emergencies were 5. So simultaneous high acuity cases can divert key staff and resources away from emergency. So it's very important to use effective escalation protocols to call in additional senior staff early when it is noted that labor ward activity is high. Next, please. And transfer to theater were in 3 cases and operative difficulties in 2 cases. Next, please. So next steps in future audits are implement recommendations, share the findings with all relevant teams, midwives, obstetric, theater, and anesthetists, education and training, include delay reduction strategies in teaching sessions, induction weeks, raise awareness of documentation standards to reduce unknown cause entries, monitoring, set measurable targets, increase percentage of decision to delivery targets met, and future audits re-audit in 6 to 12 months to measure the impact of changes. Thank you.
I'm working as a intra-specialty registrar in the Department of Obstetrics and Gynecology in Northeast University Hospital in the UK. So the topic of my presentation is, it's an audit of postpartum bladder care. This audit we have done in our hospital to assess the postpartum bladder care, to assess our practice and outcomes. So to begin with, as we know, postpartum urinary retention, it's a common condition that follows childbirth. Usually the incidence ranges from 0.05% to 14.1%. There are 2 types. One is overt postpartum urinary retention. The another one is covered postpartum urinary retention. So overt means it's an inability to void within 6 hours of normal vaginal delivery or within 6 hours of catheter removal in case of cesarean section. Covered PUR is the patient is able to void, but when we check the postvital residual volume, the postvital residual volume is more than 150 ml. That is covered postpartum urinary retention. Though it's a transient condition which may resolve spontaneously in majority of the cases, it is important to recognize and manage it early to avoid these complications, such as bladder overdistension, prolonged bladder underactivity, long-term self-catheterization, recurrent UTI infections, and overflow incontinence. So why this audit is relevant to our trust? So to ensure the postnatal bladder care, our postnatal bladder care aligns with the trust policy as well as NICE guidance NG 192 that clearly states the timing of catheter removal in postpartum patients, and to support safe and high quality care, to reduce the complication, especially to shorten the hospital stay for the patient, and to provide data to guide ourselves, our staffs and training, and for the service improvement as well. So what is the rationale for this audit? As we know, bladder care, it's an important vital component of the postnatal management. As I mentioned earlier, NICE NG 192, this is the NICE guidelines on cesarean section, and our trust bladder care policy set a clear and evidence-based standards for catheter removal, as well as timely voiding, bladder volume assessment, and documentation of all these components. So auditing our practices against these standards to evaluate our own compliance with the national as well as trust bladder care policy in the postpartum period to improve the service provision. So, and to highlight the areas of improvement and to inform the action plans to enhance the patient care as well as the clinical outcomes. So these are all the auditing standards I'm going to present. So catheter removal timing, the NICE clearly states that for women who have had a cesarean section under spinal anesthesia, the catheter should be removed when the patient is mobile, but no sooner than 12 hours after the last top-up dose. That means after the last epidural top-up dose. So for the spinal anesthesia, we can remove the catheter once the patient is mobile. For epidural, the catheter should not be removed before 12 hours from the last dose of epidural. So the standard should be 100% compliance with the timing based on the anesthesia as well as the mobility of the patient. The second component is timely voiding after delivery or after the catheter removal. So our standard is no woman should go beyond 6 hours without voiding after normal delivery or after the catheter removal. Again, the standard is 100%. Women should be void within 6 hours of normal vaginal delivery or within 6 hours of cesarean section. If they can't, we should do a bladder scan, assess the bladder volume. So that brings up our next assessment, that is bladder volume assessment. So if the patient cannot void within 6 hours of normal delivery, or if the patient cannot void within 6 hours of catheter removal in case of cesarean section, or if the patient has voided less than 200 ml of urine, the patient should receive a bladder scan to assess the bladder volume. If the bladder volume, if it is less than 150 ml, we don't have to do anything, encourage just a fluid intake and reassess the patient in 2 hours whether they are able to void or not. If the bladder volume is between 150 and 400 ml, we have to we have to empty the bladder by using either in and out catheter. If the bladder volume is more than 400 ml, we need to insert a Foley catheter and give bladder rest. So again, the standard is 100%. The patient should receive appropriate intervention based on the bladder volume. And documentation, all assessments, including catheter insertion, removal, first void volume, first void time, and plan must be documented. So coming to the methodology, I have taken all the patients who underwent cesarean section in the month of May in 2025. So the total number of sample size is 83. I have taken details from a tracker. This is an electronic patient record, which we use in our hospital, and BadgerNet, that's also another electronic patient care record. So I have collected samples from these electronic patient care record, and I used Excel for the data collection. Of the total 86 patients, 3 patients opted out of data sharing. So our sample size is 83. So these are all the results. First, the catheter removal time. The catheter was removed 12 or within 12 hours in only 14 patients. That comes around 16.8%. And the catheter was removed after 12 hours in 69 patients, that is 83.1 patients. And the reason for delayed removal was documented in only 4 patients. This indicates low compliance with the catheter removal timing. Next, first void monitoring, the time of first void. Of the total 83 patients, 10 patients had their first void after 6 hours, that is around 12%. And the first void timing was not documented in 5 patients. And next, comes to the first void volume, the first void volume that was less than 200 ml in 11 patients, that comes around 13.2%, and the first void volume was not documented in 11 patients, that is 13% as well. So coming to the post-voidal residual measurement, the post-voidal residual volume, post-voidal residual was recorded in 19 patients, but was done in only one patient, and none of our patients received recatheterization. So continuing with the auditing results. So regarding documentation, we managed to document, there was a good documentation in 53 patients, that comes around 63.8%, and there was an incomplete documentation in 30 patients, that is 36%. So next comes to the second void monitoring, that was recorded but not documented in 10 patients, but we did manage to measure second void in 9 patients. When we managed to measure the second void, there was a more than 6 hours delay in 5 patients. So when I summarize the key findings of my audit, this audit reveals a low compliance with the trust as well as NICE standards for postpartum bladder care after cesarean section. Delayed catheter removal after 12 hours was a common and occurring over 80% of the cases, with a minimal documentation for the reason for delay in catheter removal. There is a notable lack of monitoring for the first as well as second void, as well as near total absence of postpartum residual assessment in most of the cases when it is clinically indicated. Obviously, there is a documentation gap, so that limits our accuracy of the audit. So this is another reference I have taken from enhanced recovery following cesarean birth. This definitely indicates that the early mobilization should be encouraged 6 hours post-operatively. Once the patient is mobilized, the catheter should be removed, and the patient should pass at least 200 ml of urine in a single void within 6 hours of catheter removal. So this policy again definitely indicates that the catheter removal and timing of voiding the importance of the bladder care in postpartum period. So this is the action plan that we have proposed. Timely catheter removal is important thing. So remove catheter once the patient is mobile to complete the trial without catheter as early as possible. That reduces the hospital stay for the patient, as well as it gives the next thing is bladder care pathway. So this is the Badger Net. This is the electronic patient care record we use to document all the obstetric patients thing. So to ensure accurate as well as complete documentation using a bladder care pathway in Badger Net, and staff education is important in bladder scanning. So to train staff in performing the bladder scan and to interpret the bladder scan and to take action based on the bladder scan. And our plan is to re-audit after this action plan in 3 months' time to reassess our compliance and outcomes to ensure the improvement. Thank you. Yeah.
My name is Hafiz Rajput, and I'm currently practicing in the United Kingdom. I'm presenting a multi-center study on the impact of antibiotic stewardship programs on the management of pelvic inflammatory disease. This is a clinical issue, a public health issue, and a reproductive future issue. So first, let's ground ourselves in the clinical background. Pelvic inflammatory disease remains a major reproductive health concern worldwide, particularly among women in their reproductive years. It results from infection ascending from the lower genital tract. If not treated appropriately, it can lead to chronic pelvic pain, tubular scarring, subfertility, and ectopic pregnancy. So PID is not just an acute episode, it can shape a woman's long-term reproductive future. In many healthcare settings, especially in resource-limited environments, practice varies widely. Some patients receive antibiotics that are too broad, Some receive courses that are too short. Many stop early when symptoms settle. This inconsistency fuels recurrence, complications, and antimicrobial resistance. So with that context, here is why stewardship is necessary. Uh, the central challenge in PID treatment is inappropriate antibiotic use. Overuse, underuse, or incorrect choice accelerates antimicrobial resistance, making common infections harder, longer, and more expensive to treat. An antibiotic stewardship program is a coordinated approach that supports clinicians to prescribe the right drug at the right dose for the right duration, and only when needed. It does not restrict clinicians, it improves consistency and safety. So our question was straightforward. If we embed stewardship in gynecology departments, do outcomes improve for women with PID and for the health system in general? So what exactly did we set out to measure is to assess we have to assess we first was clinical outcomes in terms of recovery, recurrence, and treatment adherence. And second was system level outcomes in terms of hospital admissions, referrals related to resistance, and treatment duration. By addressing both, we assess not only how patients do, but how the entire system performs. So let me outline the design and the scale of this study. This was a multi-center observational study across 5 tertiary hospitals from August 2022 to July 2024 in Pakistan. We included 390 women diagnosed with PID, 190 before stewardship, and 200 after the implementation. The multi-center nature strengthens real-world applicability, capturing variation in clinicians, patients, and resources. Diagnosis must be consistent if the treatment is to be consistent. So we follow the CDC criteria, that is pelvic or lower abdominal pain, plus cervical motion, uterine or adnexal tenderness. Where available, we added laboratory markers and ultrasound findings. Consistent diagnosis reduces variability and directly improves treatment consistency. So which organisms did we actually see and why does that matter? Microorganisms that we identified were consistent with global experience, which included Neisseria gonorrhea, Chlamydia trachomatis, Mycoplasma genitalium, E. coli, and mixed anaerobes. Crucially, we observed clinically significant resistance, particularly in gonorrhea and E. coli. This means empirical choices must reflect local resistance, not just textbook expectations. So what exactly did our program involve? We embedded 4 practical components. Number 1, with standardized treatment guidelines aligned with WHO and local resistance data. Number 2, clinician education and reinforcement. Number 3 was prescription audit with structured feedback. And last one was integration of resistance surveillance into day-to-day decisions. Those steps are low cost, scalable, and sustainable. So did this actually change prescribing behavior? It did. So after implementation, use of guideline compliant regimes, especially ceftriaxone plus doxycycline and ceftriaxone plus probenecid, increased substantially. And we also noticed that use of non-recommended combinations fell sharply. This is sustained behavior change and not just a short-lived effect. And now let's see if this change translates into better outcomes. We observed clear improvements. Full recovery rose from 63% to 79%, meaning fewer women with persistent pain or discharge, which is obviously very good. Recurrence fell from 12% to 4.5%, indicating more effective eradication and better adherence. Adherence itself improved from 57% to 85%, reflecting clear guidance and more consistent counseling. Treatment duration also reduced from 11.6 to 9.2 days, shorter courses without compromising outcomes. In short, it made clear that that the stewardship programs get it more better and more efficient. And if we go beyond individual patients, and we look at the system level, so we noticed that there were improvements in hospital admissions for PID decreased. Referrals linked to antimicrobial resistance also dropped, and repeat presentations reduced. Together, these changes lower burden on services and improve access for other patients. And why do these results matter to us as clinicians? Is ultimately, stewardship protects reproductive futures. Reducing recurrences lowers the risk of tubal damage and later subfertility. Standardizing care ensures equitable quality regardless of which hospital a woman attends. Reducing unnecessary antibiotic use slows the march of resistance, preserving effectiveness for future patients. So stewardship is not merely a prescribing policy, it is a reproductive health intervention. And a quick word on strengths and limitations. So the strengths included that it has a multi-center scope, it was large and real world sample. Limitations were that it had, sorry, one second. Limitations were it had observational design, variable access to molecular diagnostics, and long-term fertility outcomes not captured within the study period. These obviously inform priorities for future research work. And I will draw this together in one message that antibiotic stewardship programs significantly improved outcomes in PID, clinically and at the system level. They are achievable with practical steps, guidelines, education, audit feedback, and resistance surveillance. So so programs like this should be integrated into gynecological practice, especially in resource-limited settings. Thank you for your attention.
Yeah. Thank you, Hafiz, for this
case which I've been part of in India. This is a fetal left hypoplastic heart syndrome, intrapartum postpartum management. Next slide, please. So I'll be talking on case details, diagnosis and management, intrapartum management, and postpartum management. I have included some intraoperative videos, pictures, and also the postoperative recovery of the baby. So all these pictures have been taken with patient's informed written consent, and anonymous has been maintained to maintain ethical standard, and this is only for the educational and evidence purpose. Next slide, please. This case was from a periphery of Maharashtra, actually. She's a 30-year-old, gravida 2 para 1, 37 and 6 days pregnancy with fetal congenital complex heart disease. She was registered at community hospital and she missed her 5 months anomaly scan, and then was diagnosed with having a fetal left hypoplastic heart syndrome at the 27 weeks of gestation. Antenatal period was uneventful for her. She was well immunized. Previous normal delivery, a male child, uneventful intrapartum and postpartum period. This is a second pregnancy, no allergies, no past medical or surgical history. So she was referred from the community hospital to a higher center, tertiary care center with all the multidisciplinary team management to have the all possible sort of management for the baby and for the baby survival. Can we move on to the next slide, please? So when she arrived at our hospital, she was, vitals were stable, abdominal uterus was relaxed, cephalic presentation. On vaginal examination, she was around 1 centimeter vertex presentation. We did one scan at our hospital, and it was a single live intrauterine pregnancy with 2.7 kg baby weight, normal like a volume Doppler. Hemoglobin was stable and blood group was Rh positive. So when she came at our hospital, we included all the teams, including fetal cardiologist, pediatric cardiac team, pediatric cardiac anesthetist, as well as obs and gynae team. Can we move ahead to the next slide, please? So as we all know, in fetal left hypoplastic heart syndrome, there is an underdeveloped left ventricle, underdeveloped aorta, underdeveloped mitral valve, and also the left atrium. So in these cases, the oxygenated blood to pump out from the left ventricle to the complete body, it doesn't happen when the baby is born. And that is why the emergency management is required. Otherwise, baby will deteriorate immediately in view of hypoxia and not getting oxygenated blood. So this is the baby's echo, which was done on her admission by the fetal echocardiologist. Can we move on to the next slide, please? So informed written consent was taken from the parents, and she was booked for the elective cesarean section following all the multidisciplinary team discussion, and neonatal cardiac team surgery and everything has been explained to the parents, and they were very keen to do all possible interventions required for the baby's survival. Can we move on to the next slide, please? So as per the MDT plan, we involved obstetric team, pediatric cardiac team, pediatric cardiologist, cardiac surgeon, intensive cardiac team, and ICUs were aware. Neonatal team was informed. From obstetric point of view, our main action, which was decided as per MDT, is to allow the placental fetal perfusion, delay in umbilical cord clamping, to allow have a bedside on operation table baby's echo, to make sure that the fetal foramen oval, whether it is present or it is absent. In view of absence of foramen oval, it requires an immediate cardiac surgery on the baby. And if the foramen oval was intact, then the plan was to transfer baby to the cath lab and have a balloon valvotomy to have oxygenated blood flowing from right atrium to the left atrium. Can we move on to the next slide, please? And also from our side, to maintain a uterine tone, we delayed to give oxytocin just to allow good placental perfusion and allow fetal cardiologists to have a echo on bedside. So as I discussed, as per the management plan, intact interatrial septum, pediatric cardiac operation theater was ready with the pediatric cardiac operation team, surgeons and anesthetists, to plan to go ahead with Norwood-Sanoshan procedure. And if the foramen oval were present, then the plan was to transfer baby to the cath lab, which was kept ready with all the team members for the balloon atrial septotomy. Can we move on to the next slide, please? So this is a video which I have added. We can play this video if it is working. So the fetal cardiologist is, can we move on to the previous slide, please? Yeah, I'm not sure if the video is working, but yes, here we can see the cardiologist ready for scanning and echo on operation table as soon as the baby is born. We were having delayed cord clamping to allow the perfusion and to diagnose what exactly we want to do next. Can we move on to the next slide, please? So on the echo, which was performed on operation table, we found out that intact interatrial septum, it calls for an immediate surgery. So baby was stabilized by the pediatric intensive care team, and intravenous prostaglandin was given to keep the patent ductus arteriosus open. And baby was transferred immediately to the cardiac theater for the Norwood-Sanoshan procedure. So baby girl underwent neonatal cardiac surgery at the age of 45 minutes. Just to mention here, baby's lactate was 4 when baby was born, and when baby was transferred to the theater, baby's lactate went up to 7. So it was an emergency surgery which was done, and was transferred in a stable condition in the pediatric cardiac ICU following the surgery. Can we move on to the next slide, please? Yes, so I'll be just speaking on the Norwood-Sanoshan procedure. As we do not have a left ventricle, we have to make this right ventricle work and pump the oxygenated blood to the body. So in this procedure, they create a shunt, which is from the right ventricle to the pulmonary arteries, and they they switch the pulmonary artery as well as aorta, so that through that we can pump the oxygenated blood, and the shunt is created just to make sure that there is not much overload on the right ventricle. So can we move on to the next slide, please? This is the picture from the pediatric cardiac theater where the baby's vitals were stable and they were operating on the baby. Can we move on to the next slide, please? This is a post-operative day 6 in a pediatric neonatal cardiac ICU picture. Baby was on many inotropes, but was in quite stable situation. On day 5, baby deteriorated, but then on day 6 onwards, there was continuous improvement with IV antibiotics and inotropic support. Can we move on to the next slide, please? So following this, baby actually had a successful now root Sanoshan procedure. Plan was to have a Glenn procedure, which is again to have a superior vena cava, which is attached to the right atrium, to attach that directly to the pulmonary artery. And Fontan procedure is to create another opening in the pulmonary artery from the inferior vena cava directly to attach that, so that all the deoxygenated blood is then going to the lung, and we have right ventricle, which will act as a ventricular oxygenated pumping support to the baby's body. Can we move on to the next slide, please? So baby was discharged home after 2 months of successful stay in ICU and with uneventful recovery. Can we move on to the next slide? So take-home message from this is early diagnosis, parental counsel regarding prognosis and management option, consideration of pregnancy and termination if diagnosed in early gestation age, comfort care. Sometimes the supportive and palliative management is the utmost priority and importance. In cases of late diagnosis and where the parents are very keen to do every possible procedures on the baby and the successful outcome, referred to the tertiary care center with the optimal intrapartum and the postpartum management is very ideal. Multidisciplinary counseling and approach, involvement of obstetrician, cardiologist, pediatric cardiac surgeon, and intensive care team plays very important role. This procedure for hypoplastic left heart syndrome involves 3 stages, that is an Norwood-Sano shunt, Glenn procedure, and Fontan procedure. Can we move on to the next slide, please? I think that is it for today's presentation. So it requires a teamwork and meticulous planning for optimal outcome of the neonate. Thank you so much.
Yeah, thank you, Bhargav, for your presentation.